Stanford University.
Well, good evening, everyone. Great to see you all here tonight. This is a little bit better for me to be with you than sitting on a plane to Brazil last week, which I was doing. I hope that last week's session was really great, and it's hard to believe that this is, as they say, our penultimate session. One more to go after this, but they're both wonderful topics, and I think you'll really enjoy the presentation. So just to sort of frame this for a moment, as some of you know, I spent a big part of my life doing pediatric oncology, and when you diagnose cancer in a child or indeed an adult, it takes millions to billions of cells before you can actually see the lesion. So for example, if you have a child with acute leukemia and you do a bone marrow to look to determine whether or not there's leukemia in the bone marrow, it generally takes about 10 to the 9th cells before you'll see anything on a smear. And it will take, close to a billion, many millions of cells before you'll see even a small lesion on a chest X-ray. So cancer, when we diagnose it today, is usually well far advanced beyond the initial phase of the conversion of cells from normal to abnormal. And really one of the great opportunities and challenges going forward is the whole concept of early diagnosis, and that is the theme for this evening's presentation. Now, last week you heard from Ron Levy, who is certainly one of the pioneers in cancer treatment. Tonight you're going to hear from Dr. Sam Gambhir, who's truly one of the pioneers in early diagnosis and the whole new and emerging field of what we call molecular imaging. So Sam Gambhir, like a number of our faculty, started out in a physical science. So he was a physics major at Arizona State University and then moved west to UCLA, where he entered the MD PhD program. So he did his MD and his PhD at UCLA. And there he began working in the field of biocomputation, bioinformatics, and applying his physical sciences background to really the elucidation of medicine. His career after medical school brought him into the field of radiology and specifically the domain of nuclear medicine, which is an important way of tracking and tracing nuclear isotopes as they may highlight a specific site of either inflammation or malignancy. And in the process of doing that, as you'll hear from him, he has really led the field in new approaches to using these technologies for early diagnosis. So he's leading a new center here at Stanford called the Canary Center. It's part of a national network of centers founded and supported through the Canary Foundation. And he's leading our program in molecular imaging as well, which goes from experimental to human application. His career has really zoomed, as far as I'm concerned, in terms of worldwide recognition. There isn't a place I go where someone doesn't know about the work that Sam Gambhir is doing. And it's already been lauded by a number of very prominent awards from various professional societies, including election to the Institute of Medicine of the National Academy, which is absolutely the most prestigious honor that you can get when you're coming through the medical route of education. So tonight, I think it's a real treat to hear from Sam. Now, he is, I would also say, having been with him on a number of occasions, one of our most eloquent presenters. But there is a caveat tonight. And that is, as I walked in and said, "Sam, how are you doing?" He said, "I think I'm doing okay," which means that his voice is at the edge of audibility. Now, he's been mic'd, and we'll see how far we get, but this is not his fault. This is some aberrant infection that's gotten in the way of our Mini Med School, and so I'm pretty unforgiving about the infection, but pretty forgiving about Sam. So bear with him, listen carefully, and I'm sure you'll learn a lot. Sam.
Well, it's a pleasure to be here. Again, I apologize for my voice. We'll see how long it lasts. I'll dance for you if my voice goes out. So this is a very exciting area, as I hope to be able to convince you. And as has been the format for this class over the last many, many months, feel free to ask anything at any time. Matter of fact, I love questions and love your thoughts on things that we might do differently. Because in fact, your insights sometimes are the most profound things for us, especially when you're coming from different fields. So let's start with what really matters, what we're taught as medical students and as young physicians, but we often forget. And what really counts is the patient. And many of you have found yourself in the situation that this husband finds himself in. And for those of you that have not, you've been very fortunate. And you're going to ask, when you're in this situation, why was this disease, in this case cancer, not diagnosed earlier? Because what you're going to see is that there are fewer and fewer options the later the stage of the disease is, the later the cancer has been diagnosed. And it's going to cross your mind over and over that, boy, had this thing been caught earlier, maybe even just a year earlier, 2 years earlier, there could be potentially a radically different outcome for the loved one in question. And this same issue motivates me. My own wife has cancer. Many of my relatives have had cancer. I'm sure many of your relatives have had cancer. It's a disease very few of us will escape in terms of our own personal experience. And we've started to take this question very seriously and started to ask, why can't we do better? And how do we develop the next generation of technologies that will do better for diagnosing the disease early? If you look at almost any cancer type and you plot the chance of surviving on the y-axis and the chance or the stage of the disease on the x-axis, the curve always looks very similar to this. That is, when you catch the disease out here, the chance of surviving are very low, 10%, 20%, et cetera, for many cancers. Yet, if you could catch the disease here, you might be able to bring the odds up to 80%, 90%. We see this time and time again for cancers that we actually catch earlier. Now, why is it then that in this country and elsewhere, we put 100 times more money and effort into late-stage disease? A lot of what we go after, including drugs for cancer, would in fact do much better if we could catch and work on the disease earlier. The same drugs that exist now, if they could be applied when a tumor was just a couple of millimeters in size, could change dramatically the efficacy of that drug. Well, the National Institutes of Health, even companies, diagnostic companies, academic groups are finally starting to get this. And so research funding is shifting in this direction. So let's fast forward maybe 10 years. Yes?
Can you just define the difference between stage 3 and 4?
Yeah, so it's a good question. This depends on the exact cancer type, but in general, stage 3 is still local regional. It still hasn't spread very distantly, like in metastases to another organ. Stage 1, of course, is it's exactly in the local site, hasn't had a chance to even become regional. So it's really a spectrum. In reality, you can think of the cancer originating at one site and then, of course, disseminating throughout the body. But this difference is still minimal compared to the difference between hair and hair. And we really want to push back to hair. Yes?
I just had a question. It seems like it falls precipitously in the stage 1 to 2.
Yeah. If I were to plot specific curves for each and every cancer, they'd vary a little bit. Some would not fall as precipitously there. They'd be a little delayed. Some would be flatter. But why it starts to fall, as soon as you've let the cat out of the bag, as soon as you've got 100,000 cells, 1 million cells, the chances of those cells leaving that site, even though we can't see that they've left, become higher. And then after several years, we see the metastases at distant sites.
So then what you're saying is after stage 1, basically it's not just in situ or encapsulated?
Yeah, after stage 1 in many cancers, it's already started to move regionally and now has even the potential to be further spread than we're able to detect. Even these stagings are flawed because how do you stage someone if you really can't see everywhere where the cancer cells are? So these stagings are based on what we can currently see, and why we stage is it's able to help us predict chances of survival. So if we fast forward maybe 10 years or so, let me take you through a hypothetical scenario of what it may look like for all of us over the years to come. And a lot of this will marry together courses you've had over the last few months. Of course, every good patient will be treated at Stanford. So we start here. Here's a person with a smoking history. They've had this history, but don't know they have any cancer. They get an email. The FDA talks about a new test for someone who might have risk for lung cancer, okay? And it says, please contact your healthcare provider. Hopefully we're entering a stage where a lot of this is information-based, okay? So our patient comes to Stanford and has a simple blood test taken. And then we're going to look at specific genes. We're going to look to see, does this patient have potential risk for having lung cancer? You might say, why wasn't this done when he was born? Well, eventually it will be, but this is just 2020. Maybe by 2050, all of this will be done when you're born. We're looking at his genetic profile, looking for a specific defect. And in this case, he has a defect, a specific base that's different in one of his genes, which makes him at risk for lung cancer. Can you still hear me, or am I totally dying? I apologize. It's more painful for you to listen to me. Okay. So.
Would you like some lozenges?
Thank you. I actually have one already. There is a doctor in the house. Phil. So after combining this information with other things, including his smoking history, his chest x-ray, all the information that's simpler to get, we actually have for him recommendations. We can tell him that his current lifetime risk of lung cancer is 76%. If he were to quit smoking, it could drop to 55%. With specific nutritional changes, down even further to 48%. And hopefully, we will be at a stage where we can even offer preventative medication, dropping his chances even further. Now, this is hypothetical still, because we don't have good ways to predict all of this, but that's part of the research that's ongoing. So then, this patient goes away. He doesn't have cancer yet, as far as he knows, but eventually, because he's part of a screening test and getting screened yearly, 2 years later, from a simple blood test, we start to look at all the proteins in his blood, start to see if he has telltale signs of proteins in his blood that might be indicative of early cancer. And in his case, that protein analysis and signatures of proteins in the blood tell us that, in fact, he likely has cancer. So in his case, this particular case, after 2 years of screening, we find that he has proteins that are circulating in his blood. And we'll come back and explain how all this can be and how we're actually developing the tools to do this in a little bit. But those proteins in the blood tell us that he likely has lung cancer. Now, that doesn't mean he does, and we need a way to verify it. So we proceed to the next test, an imaging test. So far, he's had simply a blood test, but we need more verification because the blood test could be wrong. It could be that he doesn't have cancer. So we start to image his body at the molecular level. We'll talk about how we do that. But basically, unlike what Jeff Rubin taught you about anatomical imaging, molecular imaging lets us look at the early signs of cancer, the proteins that are being made by cancer cells that are not being made by normal cells. So we send in little imaging agents into your blood that go and home in on the tumor. And now when we image you, those imaging agents send a signal telling us that they've homed in on a tumor. One of the techniques to do this is called PET imaging, positron emission tomography. But what it does is it produces an image like this, and it can be superimposed on the anatomy. And you can see in his case a small area where these imaging agents have homed in and told us, in fact, there's a little cancer hiding in his lungs. This is molecular imaging because the anatomy in his lungs wouldn't show a difference. It would look like normal lungs. But the molecular agents we've injected into his body are designed to seek out cancer cells and send a signal, and that's what you're seeing there. So he's got a small, tiny nodule in his left lung, and now he has a 99% risk of having cancer. Even the imaging test won't be perfect. But it, combined with the blood test, tells us that he likely needs surgery. Yes?
Would you have done the blood test had he not been a higher risk predisposition?
So eventually, the goal would be to do it on everyone. Initially, why it would only be done on high risk is that tests have to be very accurate in order to work well in the population as a whole. If you go to the drugstore and look at the early pregnancy test, it's 99.998% accurate. If the early pregnancy test was only 95% accurate or 98% accurate, there would be a lot of women thinking they're pregnant when they're not. So the problem in developing blood tests, imaging tests that are applied to everyone, including people that have a very low chance of having disease, is the test has to be very accurate. So initially, these kinds of tests will be used on people at greater risk than the normal population. In this case, we knew he was at greater risk because he had a genetic profile that told us he was at risk, and so he entered a screening program every year. To repeat the question, issue is, in other cancers like prostate, it might not do much good with me repeating it because hopefully they'll hear me, but it might be better off having you yell it. But the issue is, look, for prostate cancer, slow-growing tumors, what do you do if you catch these early quote-unquote cancers? Is it really important to intervene or not? And it's not the case that for every cancer you would do the same thing. But the real heart of your question is the following. When we mean early cancer detection, we mean early relevant cancer detection. Cancers that would go on to kill you, as opposed to cancers that would grow but not go to kill you. And we'll talk about how we'll figure out an early lethal cancer from an early non-lethal cancer as we go. But it's a very relevant issue. Because if I started looking in all of you using technologies that I'll show you, maybe I'm gonna find that everyone has something. What are we gonna do with that? Well, that's why we have to distinguish not just that you have something, but that you have something lethal that will matter in a few years. There was another question somewhere. Yes?
The blood test, it's not the circulating tumor cells that we're testing for.
Yeah, so that's a good question. It can be, but the thought right now is what we're gonna be looking at in the blood are proteins. By the time tumor cells are circulating in your blood, that might be too late from an early cancer detection point of view. But there are some people who feel that even at a very early stage, circulating tumor cells could be present. So we don't want to give up on that yet, but we'd probably be looking in blood for proteins.
So is it primarily for solid tumors that this technology is focused on?
No, as we will see, it can be applied to liquid tumors like leukemias, lymphomas, or solid tumors like lung cancer, prostate cancer. Okay. Please ask me more questions so I can rest. So, okay, so now he might have lung cancer. We think 99% chance he does. We're now also developing new kinds of agents that go and treat his cancer, as you know, very targetedly. As a matter of fact, the same things that can be used to image the cancer can go into his body to help destroy the cancer. These are very specific, hopefully, for the cancer, unlike current chemotherapies, and can spare normal cells much better than we currently spare normal cells. Because we can catch the cancer early, these therapies have a much greater chance of working. It's not that some of the therapies we have now are so bad. They're just applied in the worst possible time, when there's too many cells that are the cancer cells for the therapies to have to work against. So in this particular case, we keep going. We analyze now the tissue from his cancer that we've isolated in his lungs. We look at the genes and proteins in his actual cancer to see what is the best way to possibly treat him in the long run so as to prevent recurrence. We have the ability to look, as you've learned in other classes, in detail at the tumor once you have a sample from the tumor. So that tells us that he can actually receive specific drugs specific for him that have the best chance of working for him, so-called personalized medicine. Okay. Then he's now a member of an electronic cancer care group. And in fact, as a member of this, he continues to get email, unfortunately. And in this case, he's told that, look, we've analyzed your tissue, we've analyzed samples from you after treatment. We think that, in fact, you have a good chance of cure, but we're gonna have you test yourself every 6 months. You might even test yourself with a chip that I'll show you in a few more minutes. And you might even do it at home. And all this information lets you become your own guardian, letting you do some tests even in the home to let you be sure that you aren't recurring, for example. Now, some of this seems like a science fiction, but as you'll see, it's not that far off relative to the progress that we've already been making. And before we now talk about the science with that big picture vision, the vision can be questioned in many ways. For example, why use blood? What's something else we could use instead of blood that's even easier to get from all of you? Your urine, right? Get urine, you gotta pee every day. I don't know if you have to spit every day, but you do gotta pee every day. I just this morning was meeting with the CEO of GE, Jeff Immelt. He was here visiting, and I've always told him that the smartest appliance in the house will not be the kitchen, like GE's predicting, but it will be the toilet bowl, okay? And Jeff always questions me because he always remembers this, but the reason it will be, as we get better and better, gee, the toilet bowl could analyze you daily, both your pee and your poop. We can get into later how it would know it's you peeing. That's a separate story. But it could send messages back to the doctor on a routine basis. It could, in fact, do quite a bit invisibly. And actually, the more you empower people by having things work in the background, the better off you are in terms of compliance. We're all guilty of that. You know, it's a little bit harder to go take a blood test every year. So eventually we wouldn't even want to have to give you a blood test. But for now, we can't quite make it work with urine. Why don't you think we can make it work with urine? Not everything gets into the urine. Cells, someone said circulating tumor cells. Circulating tumor cells don't leave your blood and get into your urine. Proteins don't leave your blood and get into urine unless you've got kidney problems. So unfortunately, the urine is not a full sample of what's in the blood, just as the blood is not a full sample of what's really happening at the tumor site. Each one is more downstream than the other. So part of the vision right now is, well, let's at least start with blood, where we would identify disease. Why blood first? Low cost relative to imaging, cheaper test to do, could be done at an annual screening physical. Then if the blood tests say there might be a problem, proceed to imaging to verify the blood test. Together the two would work better. And then in the case of cancer, we're getting very good at local treatments that don't involve even drugs. If you can really catch a tumor that's a couple of millimeters or even a millimeter in size, now you even have the option of delivering sound, if you can yell loud enough, directly to the tumor and destroy it through heating. It's not radiation therapy. It's not pharmacological therapy. It's something known as high intensity frequency ultrasound, or HIFU. We basically focus pure sound at this tumor site and destroy it. No drugs are even taken. So whether you believe it's drugs, whether you believe it's HIFU, whether you believe it's still radiation, the fact is, if you could do it for a tiny tumor, you improve your chances of long-term success. So if there's anything you're going to remember from the lecture, it's the 3 I's. Identify, isolate, and then intervene to change the outcome for the patient. Size really matters in cancer. Here's where we typically diagnose an ovarian cancer right now. A size of an onion. It's huge because the patient has very nonspecific symptoms. If you talk to anyone who's had ovarian cancer, they went back to their doctor many times complaining of vague abdominal symptoms, urinary complaints. The doctor tried to figure it out, but the last thing they suspected is there's an ovarian cancer growing. We want to change the equation so that instead of catching it the size of an onion, we're catching it the size of a blueberry or less. Very difficult problem because, as Phil was explaining so well, the number of cells you're talking about now drastically has to drop. So in the case of ovarian, but it would also apply in lung and other cancers, if you look at just a cubic centimeter, about a half an inch, which is still much smaller than that onion, that's already as many as 3 billion cells. You can bet a lot of these cells have since left that site, even more than we understand right now. Doesn't mean they've all had the chance to seed other sites, but plenty of cells have likely left, because 3 billion cells is a lot of cells. To come down to a cubic millimeter, smaller than a blueberry, we're still dealing with as many as maybe 3 million cells. And then to come down to 1/10 of a millimeter in each dimension, you can start to approach just a few thousand cells. So it's very difficult to imagine technologies that we can build that can see things this small or can detect proteins in the blood from very few tumor cells. Because the smaller and smaller the tumor gets, the less apparent it is to the body. It's making less proteins that are entering the blood. It's smaller so that imaging tools, even molecular imaging, has a tough time seeing it. So is it even realistic to be able to push down and see these kind of tiny tumors? Yes.
At what point can your own immune system defend against cancer in terms of number of cells versus when it's overcome?
Yeah, that's a great question. A lot of those kinds of questions, and I'll repeat it, what point can your immune system sort of do a good job on the tumor versus when it's overcome because the tumor is so big or it's spread so many places. Part of the dilemma in answering that question is we don't really have a handle on how well the immune system does at an early tumor stage. There have been theories that what keeps tumors in check when they're very small is your immune system. But then there's some breakthrough of that, and at larger tumor size, eventually it's overwhelmed. One of the dilemmas, especially in human cancer, is we don't really know much about early cancer because we catch it late. And so all our knowledge about what's going on is based on late stage, and I don't believe the rules apply to early tumors. Even the look of the tumor, what it makes, the blood vessels that feed it, all our assumptions are based on these larger tumors. And everything we're seeing seems to show that those assumptions don't hold. So even the assumptions about the immune system, maybe the immune system's even overwhelmed in small tumors. We don't know, because we don't have a chance to observe small tumors.
If you're detecting cancer cells or proteins in the blood, doesn't that mean that those cells have already left the site of cancer?
Okay, so when you're detecting proteins in the blood, doesn't that mean the cancer cells have already left the site of the cancer? And so the answer to that is we do know based on some human data and some animal data that the reason proteins end up in the blood, one is cancer cells secrete the proteins. Other is some of the cancer cells are naturally dying and then shedding the proteins as they die. So no, they do not have to have left their site of origin in order for proteins to end up in the blood. But as the cancer cells grow in number and spread, more protein enters the blood. That's why a lot of our blood tests right now can't look at low enough levels of protein sometimes. And we haven't had tools to look for very low amounts of proteins in some cases. And I'll show you ways we're changing that shortly. Yes?
In the example of the woman with ovarian cancer, is when she came in feeling crummy, obviously the doctor didn't think cancer is the first option, but if he or she had, is the cancer generally small enough to cause the patient discomfort at what stage, at what size?
A good question. So by the time the patient comes in and the doctor, even if he suspected cancer, by the time the person's symptomatic, isn't the tumor already pretty big? In the case of ovarian, that's definitely the case. In the case of ovarian, it might be typically already the size of the onion. And that's why it's causing bladder discomfort. It's pushing against the bladder. It's causing you to have urinary problems. That's exactly why we need an early warning system, just as like your advanced cars have indicators that go off. It's too bad we haven't evolved or haven't been designed to have little lights go off. I sometimes think we'll have to engineer that. It's the ultimate test. You have a little, yellow and red indicator. But our way of doing that is that annual physical. If you get the blood test, and in the blood we look for many different things at once, not just ovarian cancer, not just lung cancer, heart disease, other things, that's our early warning indicator, long before you would have symptoms. Okay, now, the biomarker detection blood problem is very difficult. It's not a given that tumors are even making proteins that are entering the blood. How do we know early tumors even make proteins? What if your normal cells are making the same darn proteins? You go to sample the blood, and is it really specific for a tumor or not? So finding what are the relevant proteins in the blood is a very serious problem. And then just because the tumor's making them doesn't mean they're entering the bloodstream. And if they're entering the bloodstream, doesn't mean they're entering it in sufficient quantities for us to detect. So you should in no way walk away thinking, oh, it's just easy, you just sample the blood. We know very little still about what to look for in the blood, and we don't know enough about how early we can catch some things in the blood. We have some hints, but we've really never studied cancer early enough because it's always caught so late. So even if you did all that, even if you had a protein only being made by the tumor or something else only being made by the tumor, it still wouldn't tell you where the heck the tumor is. What if I told you there's a protein that says you might have lung cancer? I don't know if it's in your left lung. I don't know if it's in your right lung. I don't know if it's in the upper part of your lung, lower part of your lung. So would we just treat someone based on the blood? Probably not anywhere near the time to do that yet. So we want other tests beyond the blood tests. Now, this whole area is often referred to as in vitro diagnostics, because what we're doing is sampling stuff outside your body. We're not putting something into your body to go find the tumor. That would be called in vivo. In vitro, because we're taking it out. And we have built mathematical models for this. We understand now what's going on with normal and tumor cells. We understand for a given protein what has to happen in terms of normal cells and tumor cells, both making the protein. For those of you that are more mathematical, we have differential equations that govern these processes, and we can kind of predict how big a tumor has to get before we can detect it based on a blood test. It's very important to define everything in a mathematical framework, because then we can do things like figure out how accurate a test has to get to be useful, okay? And so all this is in a different paper. I won't get into it here, but you shouldn't think this is all the standard medical half-baked, random fishing expedition or trial without thinking about it mathematically. It's very well thought through in terms of the assumptions we're making. And these assumptions have led us to conclude that we likely can detect tumors that are below a millimeter in size from a blood test if specific proteins are being released from that tumor. And it's likely not going to be one protein, but a series of proteins. So if there's multiple proteins coming from the tumor that normal cells make very little of, and we know how little, then realistically we can get down to about a cubic millimeter or lower for a tumor. I won't go through all that because it's not the scope of this kind of lecture, but there's a lot of that data. Now, we've also figured out another thing, and this is very unusual. When I first tell you, you're going to say this is crazy, but it works. Right now, let's say a tumor is real tiny, and it's producing proteins, but not enough. What do we usually have to do right now before we can detect it? We send you away. You come back a year later. The tumor's grown a little bit more, and now maybe it's shedding protein, enough protein for us to detect. So we started asking the question, how would we cause the tumor to shed proteins for us without having to wait for a year? Seems kind of weird. How can you get the tumor to release something so you can know that it might be present? The answer is simple. You yell at the tumor, okay? Or we shake you, okay? Literally. Although the way we do it was with a very precise sound. And you might say, well, that's bizarre. But if you look at this, this is a tumor that is normally shedding some protein into the blood, okay? Why is it shedding it? Because this particular protein is made by the tumor, it's released by the tumor, it's used for many things, but in this case, some of it ends up in the blood. If I apply the right sound energy to some region of your body without knowing if a tumor is there, the tumor starts to release more of the protein. We proved this for the first time just a few months ago. It's very unusual because what it lets us do is it lets us accelerate the process of detecting that it might be there. Okay? Now, what might be the danger in that? There's always a question. Someone asked me about this. Let's see who's going to ask it. Would you want me to yell at you to do this?
What is the level of ultrasound? Is it a diagnostic or a therapeutic level?
It's a very low level of sound. Wouldn't hurt you from what we can tell. It's not a therapeutic sound level. But what else could happen, maybe?
Could it cause the cancer to advance?
Yeah, so some people say, well, wait a second. Maybe you're dislodging some cancer cells in the process. What if you're busy yelling at them, trying to get them to release their proteins, but in the process a few dislodge and now enter the blood, and they're on their way to another organ to cause you metastases? Okay, so it's a possibility. Now, we have looked at that, at least in animal models, where we can set up these kinds of systems. We don't see evidence of that because we use very brief sound energy. It's not even disruptive to the cell membrane, let alone dislodging cells. But you never know. It has to be studied more. But we're thinking of things like this. If you've got an idea like this, please come and join my lab. Because we're looking for ideas where something unusual causes us to know the tumor's there without having to wait. We don't want to have to wait the year, 2 years. We want a stress test for that tumor. Okay. Now, this has been done in cell culture. This just kind of shows you, if you take cells, zap them with sound, you can get them to release proteins of many types. If you take a mouse and you put sound in an area where the mouse has no tumor, there won't be an increase in the blood biomarker. If you put the sound in the wrong place and the tumor's in a different place, there won't be an increase. It's only if the sound intercepts the area of the tumor. So how you could do this is a person who is going screening for breast cancer yearly would arrive, get a blood test, then they would be zapped with sound on their left breast, get another blood test, zapped with sound on the right breast and get another blood test. And we'd be done.
What would be the time lapse between?
So we think right now it's about 20 to 40 minutes. It depends on the protein biomarker. Some proteins, when they get released from the blood, circulate longer, so you can wait longer. Some disappear from the blood so quickly that you have to go and look quickly after you provide the sound. This is starting clinical trials now to see if it works. We don't know if it'll work in humans. There's no reason to believe, based on physical principles, it won't. But the real proof, the pudding, comes when we do humans.
And would the biomarker be different if you're hitting
Yes.
the
Yes.
breast cancer or lung cancer, if you're hitting the same area,
Yes.
you might be able to get a biomarker, will you be able to differentiate?
Yes, so if you're hitting one area and it's one cancer versus another, the biomarker, the sound doesn't care which biomarker. The sound affects many different biomarkers, many different proteins. So you'd have to then still know what protein to look for a bump in. And that might depend on which cancer you're looking for. And like I said, it's not likely one protein. For all of this, it's likely several proteins. Yeah. Well, in the mouse, we can do many interesting things. The question is, with the mouse, what can you do? In the mouse, we do things like we put the tumor in, because we put the tumor into the poor mouse. We put the tumor in, but we make the tumor make a protein on purpose that it otherwise wouldn't have made. We can do all kinds of tricks in the mouse to kind of study the process. We can even see a few hundred cells and see how much protein they're releasing. Because in the mouse, we can start with a single cancer cell and watch it, unlike in the human where we don't have the ability to do that.
Have you ever found a cancer you didn't put in a mouse? Have you ever actually diagnosed a mouse who naturally had cancer?
Oh, yes. You might wonder, do mice spontaneously get cancer? That's what you're asking.
No, I'm asking if it's actually worked in a mouse. I mean, where
Where you don't implant, yes, yes. If you take a mouse that gets a spontaneous cancer and then apply sound, it still works. We have several ways we do these models. One is we implant cancer cells in a shoulder area. We implant cancer cells in the organ that the cancer cells are from. And we also do this where the mouse spontaneously, it's a transgenic mouse that normally gets the cancer, and then we zap it with sound. We also do it, by the way, in the primary site and the metastatic sites. Yeah.
What does the CEA stand for?
Yeah, I'm sorry, I didn't explain that. CEA is something known as carcinoembryonic antigen. It's actually a blood biomarker, a protein that is used right now in the clinic. If you ever get diagnosed with colorectal cancer, it's one of the biomarkers we look for to see if you're recurring. So if you have colorectal cancer, about 75% of the time, you'll make this protein. And so it's a useful biomarker for us once you've already had cancer and we're looking to see if it's recurring. It's also present in about 70% of breast cancers. It's not useful in lung, okay? Again, each protein changes depending on the cancer type.
Will the particular range or frequencies of ultrasound that you're using cause the T-cell receptor to be released from the membrane?
We have not seen receptors that are transmembrane and embedded released, but I think it's possible. We have to study that more carefully. The question is, could a T-cell receptor that's usually on a T-cell, and maybe the T-cell's homed in on the tumor, can the receptor be released? And it's certainly possible. We have not observed that, but we haven't looked real hard.
How good are we now at categorizing proteins?
Well, we have many different categories for proteins. One way for these problems is thinking about, is the protein a secreted protein? Is it on the membrane of the cell? Is it intracellular? That's one classification. Another way is based on the role of the protein. Is the protein a protein involved in metabolism of the cell? Is it a receptor on the cell surface that binds to something that causes the cell to signal to grow? There's many classifications of proteins. The problem isn't as much classifications as the sheer daunting number of proteins and their variants. Unlike the genome, where you might believe there's 25,000 or so genes, there can be hundreds and hundreds of thousands of proteins and their variants. And a lot of your normal cells have them. So finding proteins that are specific to cancer becomes tricky, because after all, the cancer cells were your cells. And are they really making proteins that they didn't make when they were normal cells? Carcinoembryonic antigen, that word, the embryonic part, is because this protein is made a lot in your normal cells when you are in the womb, when you're an embryo. But then the gene gets shut off, and it's shut off. But when cancer cells come back, they start to re-express this gene. And so they make a protein that you usually only made when you were in the embryonic stage. Okay.
Are you looking at, in your clinical trial, at patients for recurrence, or which population are you looking at?
We look at different populations. What I'm going to focus on today is early detection in higher risk people. Not the whole community, but higher risk, because it's the hardest problem. We also do focus, though, on some of these same techniques being used in recurrence, in being used in response to therapy, to know whether you're responding to therapy. So a lot of these techniques work in different settings clinically, but the hardest one is early detection, and that's the focus today.
We hear about dogs that can detect cancer.
Yes.
Are they smelling a protein, and at what stage can they actually detect a tumor?
Yes. Dogs were first described to do this in Italy. There's actually a large trial in Italy about these lung cancer sniffing dogs. At the Canary Center here on California Avenue, where we study early detection, we have projects that are related to the dogs. We haven't yet taken the step of getting our own dogs, but what we do is look at the exhale breath. And in fact, there are telltale small molecules in your breath and proteins. The question still remains, though, are they specific enough? Are some of those same molecules in your breath present when you don't have cancer? And we don't know the answer to that. How can you sniff something if you don't have a dog? You can build an artificial nose, and I'll show you an example of an artificial nose in a little bit. It does the same thing the dog does, maybe not as well. We don't know yet. But you can use these ideas that there are telltale signs beyond just in the blood.
Decades-old data showed that HLA alleles were also recognized by dogs. So there could be a confusion in how to recognize what was being recognized.
Yeah, that's a good point. I would say that in all these detection techniques, whether it's a dog sniffing your breath or a blood test or a urine test, specificity is always a problem. That's why we don't think the test will ever be perfect. There's no one protein or one small molecule being made by the cancer and only the cancer. It's very hard to find that magic thing that's made only by the cancer cells, and that too by every cancer cell of that type. But if you start saying you look at a bunch of things, protein A, protein B, protein C, a combination of things increases your specificity so that you don't get false positives.
Can you explain would CEA be released in a precancerous tumor found in the colon?
What does CEA mean in a precancerous tumor in the colon? Probably not much. CEA, in this case, is just being used as an example. CEA is not likely a good biomarker in early cancer detection. Okay, why did we use it here? Because in this particular case, some of the assays we had could detect CEA easier than trying to detect a brand new protein. But I'm not advocating that CEA would be the right biomarker to use. We're going to get to other biomarkers that are probably better. Why isn't it right? Because in early colon cancer, we don't have enough data yet that supports whether it's a protein being made. Again, a lot of the information is from late tumors. You have to catch people early and then study many people to know which biomarkers are being made by many people at an early stage. That work's in progress, but we don't have a candidate list yet for colon cancer. Okay, so anyway, this is just one possible approach where by looking at the blood, you can infer something about what's going on at the tumor site. And by yelling at a part of the body, you can accelerate detection of something. The other beauty of this is you form your own control. What I mean by that is if I took blood from all of you, one of you would have this level of some protein, another of you would have this level. There'd be a lot of variability. But by taking your blood and then doing something to you and taking your blood again, you form your own control. We know whether a signal in you is real because we know the signal in you before and after the sound. Okay? Now, this is entering clinical trials, as I mentioned. Any of you interested? My real objective in coming to these is not to keep Phil happy. It's actually to get volunteers, okay? I do these because I'm looking for volunteers for all kinds of stuff you're gonna see. We need people to volunteer for these. They're totally harmless studies, okay? And in fact, we get so many graduate students that volunteer for these, but we wanna get everyone because we think that's how a lot of these techniques will advance. So now let's talk about a technology that could have only been born at Stanford. It shows you the power of Stanford. It really does. We set out a few years ago working with material science, which is a group, a department in engineering that, of course, develops materials. And you've heard about nanomaterials, nanoparticles, and all the hype. It's not all hype. I'm going to pass around a chip that has been developed over the last several years. And this chip can now do all the things we've talked about in terms of detecting things in the blood in a way which we couldn't have ever imagined. So I'll give one on this end, and I'll give one on this end. There you go. What you're looking at is the first generation of a magneto nanosensor. This is a chip that we can drop a drop of blood onto, or a drop of urine, or a drop of saliva, you name it, and it will process that drop, and then, in a way I'll explain to you, tell us about a very low level of a protein that is busy circulating in your blood or in the sample I put on the chip. How does this technology work? There is nothing like this. This is truly a big, big revolution. One of the ways this works, and could have only been born here, the heart of this technology is the same thing that's in your hard disk drives. It's the giant magnetoresistor, or the GMR. The same thing that's involved in the read-write process of a hard disk drive is at the heart of the chip that's being passed around. That GMR, shown here in yellow, is very sensitive to changes in magnetic fields. If there's a small change in magnetic field, that GMR will lead to a signal. So you might go, okay, well, I don't get it. What are you going to do? You're just dropping blood onto this thing. The GMR doesn't know anything about what's in your blood. We put on the GMR antibodies, and the antibodies will actually detect a small circulating protein, let's say in your blood. We have to know what to look for. The chip is not magical. It has to be told what to look for. It's told what to look for through antibodies that are put on the GMR. We can put antibodies for CEA, that protein we talked about. We can put antibodies for 50 other proteins that we believe are possibly circulating in your blood. Once we put those on there, the GMR still doesn't know anything's going on. It goes, nothing's happening. But now, if I apply a drop of blood and the blood has that protein in it, even extremely low levels, and I'll show you how low in a minute, that protein will be captured by this antibody. It recognizes it just like a lock and key. Again, the GMR says nothing's happened. But now we send in another protein, an antibody, that also binds to the thing we're looking for. But this antibody has a tiny little nanoparticle attached to it, a magneto nanoparticle, a particle that changes its magnetic properties in a magnetic field. Now, that leads to a small change in magnetic field. And now the sensor goes, aha, there's something present, and can now detect something in the blood or other sample that you applied on the chip. Why this is amazing is that we can now start building chips, as is being done by Shan Wang in materials science, at a very high rate. What you're looking at is real time, just like chips are built in Silicon Valley for computers. This is a chip being built, and we are spotting the antibodies on the chip all in an automated fashion. Here they go. And so what's happening is drop, 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 drop. And an entire chip is being built in real time, but with biologics on the chip. Things that will make it now able to detect what we want to detect, as opposed to doing computational processes or read-write processes. Now, this wasn't an accident. This took years of planning, and it's something we've been working on for years to try to build a chip to do exactly this task. This chip has enormous properties that we couldn't have imagined in our wildest dreams. A typical test that's used in the hospital, when someone takes blood from you and runs a blood test looking for a protein, they're using an ELISA. An ELISA is a test based on antibodies also, but it's based on optics, looking for changes in light signal. It's a light-based assay. The magneto nanosensor I just showed you can detect much lower levels of things present in the sample. log orders lower. So now, something that couldn't have been detected, ELISA says, oh, there's nothing there. There's no circulating protein, it's not present. The magneto nanosensor goes, oh no, it's there. It's just present at extremely low levels. So it lets us look for the first time at things we otherwise thought were not there, okay? And that's very powerful. It becomes enabling for us. So this chip, you'll hear about more. It's being used in several applications right now, including we now have bank blood from women. We have bank blood from women who had blood samples that they gave every year, a decade before they went on to get cancer. So you go, whoa, where'd you get that blood? Well, thanks to our friends in Vancouver and the Canadian system of healthcare, these women came in yearly for a mammogram, but also got blood. And the blood has been nicely stored. This isn't the only sample set we look at. We look at a couple of other sets, but some of these women go on to develop cancer years later, and we're looking carefully now. We're mining their blood for what telltale signs were present years before they actually had a clinical diagnosis. How do we know what proteins to look for? We have a series of suspicious proteins that we've identified in other efforts between Stanford and the Fred Hutch Cancer Center in Seattle in order to look at proteins that might be present in early ovarian cancer. Okay? So we're also eventually going to be applying these in other clinical trials prospectively, but right now they're being applied in patients where we already have bloods decades before the tumor formed. Okay. Questions before I shift gears? Okay. So now, the second half of the story. As good as these blood tests get, they may never be perfect. Could be some tumors just don't shed enough proteins or secrete enough proteins that are specific enough. So we're not counting on that. We also have the second part of the puzzle, where we send in spies into your body, and those spies are going to look for the tumor. This lets us figure out if the tumor's there and where it's there. In this case, we're going to inject spies or detectives that will go and then go find the tumor. Now, this is a trickier process because we actually have to put something into your body. But it's more powerful because it doesn't count on the tumor releasing things into the blood. It can go and find the tumor by looking at molecules that the tumor has that's unique to it, molecules that don't leave the tumor site. This is what we mean by molecular imaging. And let's talk about this a bit more, and it will start to make more sense. If you think of the human body kind of like the planet Earth, and your goal is to figure out how Earth and the cities in the Earth work, and let's say you're all part of an alien race, and you're looking to study the planet Earth, what would you do first? You might send a satellite, and the satellite might take pictures of the Earth, and it would probably focus in on the craziest part of the planet, and in fact, take a lot of pictures, and it could figure out a fair amount. It could figure out the freeways, the big buildings, and you'd start to get some sense of how cities are organized. But you still would be left with a lack of understanding of what's really going on in a city. And really, the techniques that you heard a lot about from Dr. Rubin included anatomical imaging, and that's what it's like. It's like looking at the freeways, looking at the city at this level. It doesn't tell us anything yet about what's going on with the billions of cells sitting right there. It looks at the anatomy, right? You might say, no, but it does more than that. I saw examples of where we can watch the heart beating, and we can see physiology, we can see the blood supply. But still, this doesn't tell you what's going on with cells that are living in your rib cage, cells that are living in your heart muscle. It's not molecular, it's not cellular, it's anatomical. And why that's a problem for early detection is by the time the cancer is detected, it's already big, and it's causing a change in the CT scan because you're seeing anatomically changes, but that's already too late. We want to see changes much earlier than that. You've learned in this class over the last few months all the details of how even early on cancer cells have changes, mutations in their genes that leads to mutant proteins. So we already know things are occurring long before there's billions of cells that are pushing against the bladder in a patient with ovarian cancer. So why can't we reach in and image what's going on in here? And in fact, that's what an alien race would eventually do if it had to figure out how cells were working or how cities were working. It would eventually conclude that satellites aren't enough. What would the alien race eventually do to really understand our planet? What would you do?
It has to land there.
You do what?
It has to land there.
Has to land. Better yet, it has to send a spy. An alien that can live amongst everyone, and so that no one changes their behavior. Obviously, if the person next to you is dressed in a big green suit with antennas, you're not going to behave the way you normally would have. For all we know, there are a few aliens in this room right now. Okay? Some of you might think your spouse is definitely an alien. But the alien race would conclude the same thing. To study something in detail, you've got to send in spies that blend in, can watch things going on, and can send signals back out of the body. In fact, that's what I've worked on for over 20 years now, is this concept of building these spies that go and live inside of you. And we already do this, and we're getting more sophisticated about it, as I'll show you. So if the human body's like a city, and we really want to go find problems, we want to do a house-to-house search, we want to send our spies into each house looking for a problem so that we can catch things at the earliest possible time. So we build these molecular spies. A part of them recognizes a specific problem in cancer. Another part is the walkie-talkie. It's the signaling part. After the spy sees a problem, it sends a little signal. It says, hey, Dr. Gambhir, there's a problem in the lower left portion of the lung where I've got a few bad cells. It has the ability to recognize errors because of the chemicals we use here, and this part signals. We often test these in small animals, put them into humans. That's where we need you, the volunteers. And then we start to get images, but now these images are molecular images. They're images of where the spy is present. Sometimes the spies we make send us signals all the time. Sometimes they only send us signal once they find a problem. We make different kinds of spies. I'll teach you about how we do that in a few minutes. But they're quite real. Where do they go? They eventually get peed out. The spies are eventually urinated right out of you. Sometimes they're pooped out. Sometimes they live with you for a few days, and we have some spies that live with you for a few months. We don't have spies yet that live with you for a few years, but we're working on that. We're also working on spies that bidirectionally communicate. Right now, the spies just send us signals. We can't tell them, hey, take a left turn over here, or now you're done with the heart, please go on to the liver. But we're working on bidirectional communication. Right now, the red box just tells us what's going on, and we can't tell the molecule what to do. We're sort of at the mercy of what the body does to the molecule. This isn't science fiction. It's evolving so fast that you're going to be amazed how quickly things are moving. We have to know what to look for. We don't have a generic spy. We don't have a spy. What time do we finish? 8:20. Oh, so we're okay then. Is that right? Okay.
You're okay, we're okay.
Oh, I'm fine. So we still have to know what to look for. We don't have generic spies that can find any cancer and find Alzheimer's disease and find heart disease. We don't have a generic spy. We tend to have to build spies that have to do specific tasks. One spy that specifically goes and finds breast cancer, one spy that specifically goes and finds lung cancer. Sometimes we get lucky with spies that can find several kinds of cancers. But we don't tend to have something that's so universal. That's a harder problem. One of the reasons is the spies still have to know what to look for. They got to know which molecules make something a cancer cell versus a normal cell. They have to know what molecules are indicative of Alzheimer's disease when we think outside of cancer. So we still have to cause them to recognize unique things. We test them like this, and we have to work with the Food and Drug Administration before we can put them into people. Obviously, now we're going to inject something into you, so you might go, wait a second, I don't want a spy living inside of me. Okay, but I'll convince you by the end it's a good thing to do. The spy that goes inside of you is designed to be very safe because, one, we don't give much of the spies. It's not like taking a drug. It's like taking a lick of an aspirin tablet and throwing the rest of it away.
At some point, I'm going to want, why not send in assassins?
Yes.
Basically make them highly radioactive, and
Yes.
if they collect on the cancer, just kill the cancer.
Yes. Great question. If you're going to send in a spy to detect disease, especially in cancer, let's blow it up. Let's have the spy have a black suit. He opens it, and there's bombs. And boom, things are gone. In fact, that is an evolving field. That's called theranostics, the merger of therapeutics with diagnostics, so-called theranostics. When we did that animation of the people or the lung cancer patient, I skimmed by it, but I said he's getting treated now the same way he's getting imaged. That was exactly this concept, theranostic. It's not as easy as you might think, because it's actually harder to treat than to detect, because you have to do enough damage, and you have to do enough damage to the right cells. But eventually, that's exactly what we think will happen. Eventually, whether that's the immune system or an enhanced immune system, or your spy that serves a dual role, it will hopefully act both as a diagnostic and as a therapeutic. And that's a very active area being enabled for us by nanotechnology and nanoparticles that can both act as signaling systems and killers of cells. If you want to know more, it's being done with gold particles. Yeah.
How do you prevent these agents from being modified by other proteins or enzymes?
Yeah, so you say you're going to put a spy in. How do you prevent them from being modified by other molecules in your body? Part of that is getting the spy to look like something else the body normally passes on. But other spies that we build, in fact, do get modified by the body. And in fact, we take advantage of that modification. But the real goal would be putting in something where the body has no idea it's there. The immune system doesn't recognize it. It lives with you. It's your friend. Signals to us all the time, even though you're not urinating in your intelligent toilet bowl. That would be the eventual goal, but we're nowhere near that yet. Okay. This is a complex area, and I don't want to overly simplify it, but for sake of time, we start with targets, build the spies, which are nothing more than chemical molecules, sometimes quite complex. We test them in cells. We test them in small animals. We make sure they can tell us where the signaling is. We use quantitative modeling to understand what they're detecting. Then we move them into the clinic. When I started 20 years ago, it used to take us about 7 years to go from the first circle to the last. We now do it in about 2.5. And soon we'll do it in about 1.5 years. The hardest part used to be this. People at the FDA didn't know what to do with us. They said, you're kind of like a drug, because you're giving things into the body, and you're going to have to really show us this stuff's safe. And we kept arguing, well, we're giving such a low mass level of these spies. It's lower than any level of any known poison to man, like curare, which is even at very low levels dangerous to the body. These spies are given at even mass lower levels than that. They said, no, but there could still be something that could happen. And we said, you're right, you never know. And so over the years, though, the FDA has become more and more comfortable with these class of molecules and spies. There are now 800 of them, okay? There are 800 different spies that are used for different things. Several are more common, others are for very rare diseases. But the FDA has a special branch for these now. They can target anything. The spies can target a receptor, just like a drug that's used to treat a cancer cell. The spy can target abnormal blood vessels, feeding the cancer. The spy can target an enzyme that's in the cancer cell and upregulate it. Just like you build a drug that's specific for cancer cells, you build these spies that are specific for cancer cells. The signaling part can be almost anything in the physical spectrum. We now build spies that send light. And you might go, well, that's really strange. You're saying a person can be walking around, there's light coming out of their body. And yes, we have spies now that are being clinically translated that produce light. Light doesn't do a great job at depth. If I have a spy deep inside your body and it's sending light out, most of the light never makes it beyond a few centimeters. But red light does a better job. If I shine this red laser, all of this, you'll see red light getting through my finger. If I took a green laser, you'd see nothing's getting through. Red light and near infrared light can penetrate further. So if we build a little walkie-talkie that makes light, that's one way we can signal. It tends to be used more for cancers that are closer to the surface, in the bowel. When you use an endoscope, it can light up for the gastroenterologist, and I'll show you examples of that. But light can be used. When we use PET imaging, you've all maybe heard of PET imaging, positron emission tomography. This is a radioactive atom, and a positron is being emitted from the radioactive atom, and that's leading to gamma rays. Those do real well leaving the body. They penetrate through tissue. We also use radio waves. We're currently building little RFID systems, just like you've heard about RFID in stores that track groceries and products. We're miniaturizing RFID down to levels where they can be injected into the body. That part is not yet accomplished, but the light and other parts of the physical spectrum have already been accomplished and are moving into humans. The stuff that's mainly in humans tends to use higher energy, like positron emission tomography, but that's quickly changing. Because we can't tell the molecules where to go, the spies where to go, they follow the blood and are at the mercy of the body. And so we have to design them carefully to be able to evade certain parts of the body. For example, if I put a spy in, but it's stuck in the blood, it's bound to proteins in the blood, it can't leave. And so it can't get to the tumor cell. If I put a spy in that's broken down by the liver too quickly, it's pooped out. If I put a spy in that's peed out too quickly, you've gotten rid of it from the body before it has a chance to go find the tumor. So we do a lot of things to engineer and design the spy so it can last right in the body.
Are they working on, or is there work being done on energy systems for the spies?
So you're saying, are the spies, do they have a battery source, an energy source, so they can move around? Right now, most of the spies that we use are molecular, small molecules, peptides, proteins, and they have no energy source of their own. The way they make the signal, the red box, sometimes is because they're pre-packaged with energy, like in the case of radiation. In other case, we excite them with light, which then causes them to release other light. But the actual molecular spy does not have its own motor. But in newer versions of spies that are nanoparticle-based, there's a lot of work to have them have their own propulsion systems. But we're nowhere near using those in patients. Is that your question? Yeah.
How about temperature probes? Cancer cells are supposed to be warmer.
Yeah. So there are many probes. Although I've talked about the probes recognizing a molecule, we also build probes that recognize pH, temperature, low oxygen, high sugar metabolism, so they can recognize general processes of cells in addition to specific molecules present in the cancer cell. Yeah?
What's the life of the spy after it leaves the body?
So after it's in the environment, you mean? Depends on the spy. If it's a radioactive spy, some of the radioactive spies are radioactive for another few days. Some are only radioactive for another few minutes. If it's an optical spy and it's peed out by you, it's in the water forever. But they are molecules that are not different than the molecules in your body, and the walkie-talkie part usually breaks off eventually. They're not anything I would worry that if you go to open the water faucet in your home, that you're drinking some spies. All of that gives me an idea. Okay. They're at such low levels that it would be very difficult to detect them because they're given in such low levels to begin with. But they're there, and some of them, like all molecules, eventually break down, and it depends on the molecule. And we can predict that. For a given molecular structure, we know how long before it's even broken up into specific atoms. Oh, so the journey of these spies is very tough. Here's a spy. We're going to inject it into a person. Let's say it's going to home in on a liver cancer. It's very tough to make your way in your blood, get through the cell membrane, get inside a cell, and there's the spy. There it is latching on to a cancer gene product. It's a difficult journey. Don't underestimate how difficult it is. Just like if the alien race really put spies to live amongst us, boy, they'd have to get very good at disguising them. They'd have to know how to drive a car, how to move around the city. It's a difficult task, and we're only slowly getting better and better at building such spies. The spies are not all small molecule. Some are much larger, like things that we call mini bodies. These are relatives of antibodies, but they're mini, so they get out of the body faster, which is what we need for diagnostics. Sometimes we use nanoparticles. We have large programs where we're building nanoparticles out of gold, out of carbon, and these spies let us do more interesting things. For example, they let us build more things into them, but they come at a cost. Your body doesn't like large things. If I inject large nanoparticles into you, what do you think happens? There's a thing in your body called the reticuloendothelial system, the RES, which lives in your liver, lives in your spleen, lives in your bone marrow. Its sole purpose is to gobble up large things that are circulating around. So if I inject these larger spies into you, they have to evade the RES, because the RES, the reticuloendothelial system, is designed to clear your blood of debris and things that it thinks shouldn't be there. So again, designing the spy to evade things are important. We've spent several years disguising these so that they could fool the RES, and we still haven't been able to fool the RES. I think it's got a few 100,000 years lead on us, okay, if not more. Okay, how do you actually get scanned when you volunteer right after this lecture's over? You go into the scanner, and it's about a 7-minute process. So right now, in one of the technologies, PET-CT, we would inject the spy into you. We usually give one of the spies about 30 minutes to do its job. Remember, we're not injecting just one molecule. It's still billions of molecules. They're all working together to do a house-to-house search, a cell-to-cell search. They're busy sending signals out. We're taking a picture of your anatomy with the CT, the computed tomography that you're all very familiar with, and positron emission tomography is letting us image where the spies are. All it tells us is where the spies are at a certain point in time. That leads to images that I'll show you. One of the spies that you'll see used in the hospital all the time is a very simple spy. When we started to develop this work about 15 years ago, people said, this stuff will never get into the hospital because it's too strange, it's too costly. But lots of people around the country believed it would eventually work and stuck to it. The SPY in this case is a simple sugar. It's a glucose molecule. Cancer cells love to eat sugar. Why might that be? Well, they're growing. They need to divide, they need energy. So they love to eat sugar. Let's take advantage of that. Let's give them some sugar, but not too much. But let's have that sugar produce a little signal so that we can tell what parts of your body are busy eating sugar. In fact, when you give such a molecule with a little radioactive fluorine atom, which is what's going to send the signal, it will be taken up by the cancer cells through a glucose transporter, the same way glucose enters your cell. And then it will be phosphorylated and trapped. Luckily, the rest of the cell doesn't know what to do with this thing. After it metabolizes it by one step, all the other enzymes go in the cell. This thing is not supposed to be here. What the heck is this? And eventually they break it down. But by the time they do that, we've already figured out where the molecules went. Okay? And here's a picture. This is a very unusual story. This is a person who was actually pretty healthy and young. And we had just gotten a new scanner. And he said, I want to volunteer. I want to try it out. And the last thing I would expect in this healthy person is this image. All those small spots you're seeing are, in this case, cancer. What cancer do you think it is in a young, healthy male? Say it louder, say it louder. Leukemia, someone said. Anything else? Testicular. This is why Phil's the dean. Testicular cancer. He's a healthy young guy. I mean, 20, 25-year-olds, you know. This could be Lance Armstrong's picture, okay? In fact, molecular imaging of this type is letting us see things and peer into people, still though later than we'd like. But these are not images of his anatomy. The only reason it kind of looks like a person to you is because all the cells are busy taking up sugar, not just cancer cells. Matter of fact, what part of this person is busy taking up a lot of sugar? The brain. You're only seeing a part of his brain way up at the top, but the brain loves sugar, and you're seeing the brain. But you know, all these areas, and even the reason it looks like you can see his arms and stuff is the muscles are still taking up sugar too. But the cancer cells are taking up a lot more because they love sugar. Why do they love sugar? They've upregulated two genes in particular, glucose transporter and hexokinase type 2. Those two things cause them to bring more glucose in and metabolize it, and also cause them to bring in our SPY. Now this SPY then is not that specific, is it? It's not just seeing cancer, it's seeing many things. But as unspecific as it is, if you compare to what a CT scan shows versus what this shows, it's night and day. And these, if you have the unfortunate event of having a cancer diagnosed through various strategies, this is one of the first tests you'll get in the hospital now, because we want to know where is the cancer spread, okay? And other than in prostate cancer, pancreatic cancer, a couple of others, this is a very powerful tool already. But this is at its infancy. We know we can do way better than this. We can also see tiny little areas. These are what your lungs look like on a CT scan. But the PET scan part shows the SPYs as they've homed in on lymph nodes. And the lymph nodes are harboring cancer. The CT scan doesn't know there's cancer there, because the way the CT scan would be read out for cancer is if the lymph nodes get real big. Then you go, well, maybe there's cancer because the nodes are big. This isn't based on the size of the lymph node. It's based on in this case, the cancer cells within the lymph node eating a lot of sugar. Okay? Questions?
Why doesn't it work for pancreatic cancer?
So certain cancers, for reasons that actually are becoming clearer, not all cancers are the same as you've learned. Certain cancers depend on different nutrients. For example, prostate cancer loves fatty acids, whereas breast cancer loves glucose. We are learning more about the metabolome. You've heard of the genome, the proteome. There are whole studies now on the metabolome. And cancer cells don't behave the way normal cells do with what pathways they upregulate and what their nutrient sources are. And some cancers, especially prostate, and pancreatic is another unusual one, don't tend to predominantly rely on glucose. But we're learning what they do rely on.
So can you start them?
So that's a good question. There was a study done to say, well, cancers love sugar, so let's go on the ultimate diet. And people even tried putting people in comas, bringing their blood sugar down real low, and keeping them in that state. It's just not practical to do for the time it takes to kill tumors. And then the tumors are smart. When you shut off the sugar source, they go, well, all right, I'm going to figure out how to use something else. So you start selecting for things that are not sugar. And by the way, this question has another deeper tangential issue. The way this FDG, this fluoroglucose, was originally discovered was people were trying, based on your same thought, to say, what if we give tumors things that look like glucose but aren't? And maybe the tumors will take a lot of them up and therefore get confused and not eat sugar. And in fact, that started to work. People, actually it's a great story of a gentleman who was a scientist who was dying of cancer himself, a Japanese scientist in New York. He started making all kinds of things that looked like sugar but weren't sugar. And he started testing them in cells, and cancer cells started dying. He then put them into animals. And what do you think happened? The brain needs glucose. So in fact, he gave them to the animals. It did start to hurt the tumor, but it shut off the brain. The problem with glucose treatment and things like it, analogs of it, are that it shuts off the brain. So why shouldn't any of you be scared to volunteer to get this molecule? Because we give it at such low mass amounts. Your brain, even though it's lighting up on this image, relative to the amount of glucose your brain has access to, it doesn't even know this molecule's there. How many of these studies have been done? In this case, at Stanford Hospital, there's about 15 a day. Across the world, there's hundreds of thousands. But keep in mind, these spies are given at very low mass levels. If they weren't, in this case, they'd shut off your brain. So that brings me to, there's many things we pay attention to, the things you're wondering about. How much of the spy do you have to inject? Its potential for toxicity. How does it get back out? Okay, this spy is very interesting. How is it getting out of your body, can you tell? It's being peed out. That actually is not cancer, it's the bladder. How do I know for sure? I look at the CT scan where it shows me the anatomy of the bladder. Okay, so it was peed out. Does that make sense to you? If you go home tonight, are you going to be peeing out glucose? Not unless you're a diabetic. You shouldn't be dumping sugar out into your urine. But this spy, as a pure fluke, gets out and gets into the urine. That was a major issue to its success, because if it didn't get out by the urine and it sat around circulating in your blood, we'd never see an image like this, because the molecules would produce a huge background signal, and we couldn't distinguish the tumor site from the normal site. Luckily, this thing behaves enough like glucose so that it is taken up by cells, but yet it's not enough like glucose to be reabsorbed in the distal renal tubules. It's filtered out. Yeah.
What
So this particular fellow, he's actually at UCLA, and he's fine. Testicular cancer is one of these where even as you're advanced as looking at this, it responds very well to treatment, even when it's caught relatively late. Same story with Lance Armstrong. Read his book. I don't have access to his images, and I'm not sure he'd want them shown, although he has shown them at a meeting in Texas, I think. And he had very advanced disease, including brain involvement. He said, bring it on. He took chemotherapy like no one possibly could tolerate, but many others actually are able to tolerate the level of chemotherapy that's given for testicular cancer. Unfortunately, back to our early detection story, if this was someone else, it would be very, very poor odds to make it even a few months. That's why we need to not be at this stage. We need to have performed this imaging after that blood test on that chip that's being passed around said there's a potential problem in this person. And that's what we're hoping to do. And to wrap up, so that the last 10 minutes we can keep discussing things, many technologies are being developed here at Stanford. We have the world's largest small animal imaging facilities in the Clark Center. We image 40,000 mice a year. And thanks to the vision Phil had of helping us set up these centers and the new centers and the Stem Cell Institute, where we're building another small animal imaging facility, we are able to build all kinds of next generation tools that will let us peer inside your body and detect earlier and earlier disease. Some of these don't have counterparts in the clinic yet. We're literally running a mouse clinic in the bottom of the Clark building. The problem is mice aren't insured, okay? So it's very difficult for us to do all these studies, but we managed to do 40,000 a year, and the rate at which it's growing is phenomenal because the probes are increasing. We're getting better at designing them. We're getting better at designing instruments that can see smaller and smaller numbers of spies. I'll show you one example that we've been developing recently called photoacoustic. Photoacoustic imaging sends light into your body and sound comes back out. Sounds kind of strange, but you would be injected with a spy. The spy would go find a tumor, then we'd pump you with light, and you would yell back at us. Sounds bizarre? No, as a matter of fact, we've made that work over the last few years. We take simple laser light. The laser light is input into a region of your body, let's say the prostate or the ovaries. That light is absorbed. The absorption leads to a slight heating, sub-degree type of temperature, nothing that harms your body. That heating leads to thermal expansion. That leads to pressure waves. That leads to sound. Light in, sound out. You know who originally had this idea? Alexander Graham Bell. The original patents for photoacoustics go to Alex. Talk about being ahead of your time. He was trying to make a cell phone with photoacoustics. I'll save that for some other day. But go read about Alexander Graham Bell and how far ahead he was. He had no thought about putting it in a living person, but the concepts he had were phenomenal. He had the dilemma that he didn't have lasers. He had to rely on the sun's light, which isn't energetic enough to heat things the way we want them heated. But light, sound, and then we could start to detect things. So spies can start to be detected at very good spatial resolution, very low levels, and we have built spies like this that go into your body, in this case in a mouse, and what we're able to detect are very low levels of tumors. These are spies where when we illuminate them, they send back sound. We're working with the Food and Drug Administration to get permission to put these into humans for the first time. When one of you volunteer, this will be the study you'll get. These studies are also making their way into breast imaging. How many of you have had mammograms? Okay. The mammograms of the future will not be shoot your breast with a lot of bullets and see what comes out the other side. That's what you're getting in a mammogram. It's a low energy X-ray. It says, let's shoot the breast with a lot of bullets, and let's see how many come out the other side. The mammogram of the future is send a spy that goes and searches every breast cell, and when it finds something, let it signal to us. And in fact, that's how these machines are evolving. Light will come from a spy right out of the breast, but the spy will send the signal after it's found a cancer cell, letting us see cancer way earlier. Yes?
And what you just said about the breast detection, so if you send a spy into the breast.
Into the blood, into the blood.
Into the blood that would then find the breast. Does it have the ability to differentiate between, for example, ductal versus globular versus?
Yeah. So it depends on the type of spy. The current spies we're building in optical imaging are based on metabolic properties and not cell surface receptors. But we do have a spy that targets HER2/neu, a receptor found in about 20% of breast cancer patients. Theoretically, you can distinguish ductal from lobular from DCIS. Right now, the spies can't do that. But there's no reason you can't design them to do that. Yeah.
How many years down the road will we have something like that?
We already have this system in the hospital right now, but it's currently not being used with a spy we put in. It's being used by seeing how much light makes it through your breast, just like X-rays make it through your breast in a CT scanner or in a mammogram. So we already have the machine. We're adopting the machine for spies that produce light, and the FDA has to give approval for the first set of spies about 2 years, if even that. Yeah.
So unless you inject them in sufficient quantity, I mean, they could be wandering in some other area and not go to
Yes.
tumor is, right?
Yes. So if you don't give them in sufficient quantity, you might say if you only gave one molecule, just one, well, what are the chances it's going to go to the breast? That's why we can never just give you one. We have to optimize the dose. And part of the optimization, which occurs in animals, is to tell us how much to give you on a per kilogram weight basis.
Do you want to give us an email address or website, so if we wanted to contribute an hour or two a month, we could contribute it to testing for Stanford stuff?
Yeah, I will give you that exactly at the end. And yes, I'll show you how. And I'm just teasing you about the volunteer issue. I hope you understand. We get so many volunteers. But I'm always happy to take one more. And it really, we have to match you to the right study. Obviously, if it's the breast tumor study, we're looking for certain things. But for other things, you know, males get breast cancer too, just so all the males in the audience know. One of the biggest tragedies is when a male gets breast cancer. Sorry, yeah.
Just a question about the commonality of physical characteristics of cancerous tumors. Do all of them have a higher temperature than the local area that they are embedded? In other words, is it a temperature effect, or is it also electrostatic gradient effect?
For the photoacoustics, for this technology, photoacoustics, or in general, are you saying for a tumor that has a spy that's capable of a photoacoustic signal, or are you just saying in general?
In general. In other words, because there were some questions about pancreatic being different, et cetera.
Yes.
But if you had a physical characteristic, let's say it was always 0.1 or 0.2 Kelvin higher than within 3 centimeters of the tumor, you would be able to have a heat mapping, just like we use actually in spy photography.
Yes.
So we could actually see.
Yes.
selectivity.
So I see what you're asking then. So if you say tumors might have a slight difference in temperature, and if you're just imaging temperature using thermography, and yes, that has been tried, actually in breast cancer in particular, the problem is specificity. Some things that are not tumor also have the heat map change. And so thermography has been tried, especially in certain regional tumor detection, and like many other techniques, has not panned out because of specificity. it actually alludes to a deeper question. Why do we put spies in anyway? The reason is, if you try to get signal from the endogenous properties of your tumor, whether it be temperature, whether it be noise molecules are making, it's usually not specific enough. The spy provides a lot of specificity because we engineer it to recognize a very specific thing. But we have tried, and our big vision would be to never have to inject anything into you. Remember when Dr. McCoy in Star Trek, he doesn't take the tricorder and say, excuse me, let me inject something into you, and now let me scan you. He just sort of magically scans you and says, oh. We don't quite have that ability because we can't get enough signal, enough specificity in signal. We know molecules do produce signals that we can listen in on, but when we have to look at them at a deeper depth in your body and get unique signatures, we haven't been able to come up with technologies to do that, even when they're based on things like temperature.
Try things like ultra-wideband?
We have not, but that has been tried. And there's a group at Agilent that's been looking at that. Yes?
When you reach the sensitivities that you're aiming for, do you think the fraction of the population that tests positive would be significantly different from, say, the fractions of data that become symptomatic?
So when we finally achieve the sensitivity specificity, will the fraction of patients what? I'm sorry?
Test positive at these high sensitivity levels?
Yes.
Very similar to the fractions of data that become symptomatic, or it will be different than that, maybe much larger?
Yeah, likely if these tests do well, and we set up the recognition to be for early cancers that are lethal, things that are going to impact you, not just everything, likely it will start to detect things that would have otherwise long been missed. Now, it's all conjecture because the tools are just coming online now. It's kind of like when there was no microscope and people were trying to understand bacteria. When you have the tools and power to look for the first time, it enables you to start to answer these questions. And I think a lot of what we conjecture about early stage cancer, early stage disease may in fact be quite wrong. Hopefully these tools shed insight into that. So to end, identify, isolate, intervene. Thank you very much.
So just a couple of quick things. First, things I know. I have had the chance to hear and listen to Sam Gambhir over now a number of years. I think at least, it's going to be at least 5 or more. And it's extraordinary to watch the progress of his work and that of his collaborators. So what I think I know is that what you're hearing tonight is really a prediction of the future that's almost ready. And it's going to be really transformative, which is why I was so eager for you to have this as part of the repertoire of this course, because this defines where we're going, right? So thank you all for being here. Next week rather, is our very last session, and it's on regenerative medicine. It's going to be very different from the stem cell talk that we had by Jill Helms in the first quarter for those who came to that. So I think it'll be very exciting. There you see it. It's pretty straightforward. sgambhir@stanford.edu. So with that, good night and see you next week.
For more, please visit us at stanford.edu.